McGraw-Hill Education presents The Cleveland Clinic Way, Lessons in Excellence from one of the world's leading healthcare organizations. Written by Toby Cosgrove, MD, President and CEO of Cleveland Clinic. Narration provided by Eli Woods and Company Productions. Dedication to all Cleveland Clinic caregivers, past and present, and to the patients who have trusted us with their care. Preface. Terry McCourt was expecting a baby. She was already 5 days overdue. As she sat down for dinner, she felt an unusual pain at the base of her throat. She didn't know it, but she was in mortal danger. Deep inside her chest, the largest blood vessel in her body, the aorta, was beginning to tear itself apart. If left untreated, it would rupture massively, gushing blood like an open fire hydrant. Terry and her unborn baby would die. Terry was hard to ignore as she burst through the doors of her local emergency room. She was tall and long-armed like Abraham Lincoln. And, as has been speculated about Lincoln, Terry has Marfan syndrome, a genetic disease of the connective tissue that can render the aorta fatally fragile. The disease had already killed her father and 3 brothers. Now it seemed like it was Terry's turn. Fortunately, the caregivers at Terry's Southern Ohio hospital knew exactly what to do in the case of a complex emergency that was unlike anything they'd ever seen. They called Cleveland Clinic. A helicopter arrived and flew Terry to Cleveland Clinic's advanced care facilities. With her condition worsening by the minute, a multi-specialty team that included a surgeon, a cardiologist, and an obstetrician went to work. They stabilized her and assessed her condition. She was rushed to an operating room where her aorta was clamped and she was placed on a heart-lung machine. The obstetrician stepped in and performed an emergency cesarean to deliver a beautiful baby boy. As Terry's baby was being examined, the heart and vascular team surrounded the table. Aortic rescue can be dangerous. It includes some of the most complex procedures in all of cardiovascular surgery. Few specialists anywhere have experience in the full range of techniques required. Terry's team of surgeons, anesthesiologists, technicians, and nurses went to work. They knew that it would be a long night, but they were determined that Terry would live to see her newborn son the next day. If Terry's local hospital hadn't sent her to Cleveland Clinic, she probably wouldn't have made it through the night. "We were racing against the clock," said one of the surgeons. But Terry got to see her son the next day, and after 9 days in the hospital, she was able to go home. She spent the next 4 months recovering, but eventually she went back to work as an inspector at a basket factory. Her son Seth is now in his early 20s. A typical young man, in Terry's words. He enjoys computers and spending time with his girlfriend. He also has Marfan syndrome and goes for annual checks of his aorta. Terry's case exemplifies the virtues of a unique model of medicine, a system in which caregivers work as a team. Doctors purely practice medicine, and the patient comes first. Unlike the majority of American physicians, those at Cleveland Clinic and a few other institutions aren't free agents who are affiliated with a specific hospital. They are employees of the same organization that owns the hospital, and they practice as an integrated group, behind-the-scenes facts that make a huge difference. In Terry's case, top experts in a dozen fields were able to scramble in the middle of the night to pull off a complex and unusual medical intervention. It was a seamless collaboration and the kind of everyday miracle that has captured the attention of everyone from the President of the United States to the New Yorker. We all know that American healthcare is supposed to be a mess. Yet on the frontiers of medicine, Cleveland Clinic has developed an approach to treating people that is more effective, more humane, and, surprisingly, more affordable. By reorganizing doctors and other caregivers so that they work together better, and by reorienting medical institutions in ways that embrace and enhance collaboration, innovation, patient experience, and wellness, we could solve all kinds of problems, including financial ones, that are driving our ominous healthcare crisis. We could help individuals live longer, healthier lives without bankrupting the nation. We could launch a technology revolution that would save lives. We could make visits to the hospital more pleasant and emotionally healing experiences. And we could help doctors engage with patients and with one another as people and enjoy the practice of medicine again. As CEO of Cleveland Clinic, I lead a multi-billion-dollar enterprise that has outposts around the world. But I wasn't born a CEO. I spent most of my career in the medical trenches as a cardiac surgeon, performing more than 22,000 operations, including the world's first minimally invasive valve surgery. Instruments and techniques that I invented are used in operating rooms everywhere. I know the sights, sounds, and smells of the operating room. I know what it takes to build a small, tight-knit team for surgery and what it's like to organize an entire system of hospitals. I also know the human side of healthcare. I've felt the thrill of saving a life, not once, but hundreds, even thousands of times. And I understand what it's like to lose a patient and then have to face the family in the waiting room. I love my patients and I love being a doctor, but I've never felt like a medical insider. I finished at the bottom of my class in medical school, and I was strongly advised not to go into cardiac surgery. I didn't know it at the time, but I had an undiagnosed learning disability, dyslexia. Over the course of my career, this condition has proved to be a blessing in disguise. Because of the limitations it imposed, I never fell prey to the herd mentality. I had to forge my own way of learning about and understanding what went on around me. That informs how I lead Cleveland Clinic. Across America, people have been asking, what's wrong with the healthcare system? How do we fix it? What is the best model of healthcare for these times? It's clear that some parts of American healthcare are dysfunctional. Other parts seem to work very well. Among the latter are large, not-for-profit group practices such as Cleveland Clinic. The national media have taken note and produced features and articles. President Barack Obama praised Cleveland Clinic and similar organizations on national television and visited us to find out more about how we operate. The level of interest in this organization and its methods has remained high over the years. People would like to know more about Cleveland Clinic and what we do differently. The Cleveland Clinic way arose out of the ongoing national debate on healthcare reform. Our purpose is to share the good news about American healthcare and show how Cleveland Clinic and similar organizations are shaping the future of medicine. This book draws upon my speeches, writings, blog posts, and published Cleveland Clinic communications to provide the most comprehensive and accurate account possible of the subject matter and the organization. Cleveland Clinic has kindly allowed me to quote verbatim and without attribution from authorized publications and corporate communications. The final product is a combination of my thoughts and the wisdom of Cleveland Clinic caregivers, past and present. It's a positive vision of healthcare compared with the ones that we usually see. And it's a vision that I hope will shift not only how we as medical professionals talk about medicine, but how we practice it, and how we lead our healthcare organizations, empowering citizens to make more informed decisions about their health and reigniting pride in American medicine and American innovation. The Cleveland Clinic way isn't about the complexities of the health insurance debate. It doesn't take a stand on the specifics of recent healthcare legislation, nor does it talk about how individual doctors should treat individual diseases. Rather, it's an overview of how our dominant system of practicing medicine can be overhauled for the better, giving a look at a healthcare revolution that is already underway at Cleveland Clinic, and is one that we need to further and hasten. Ultimately, I hope you'll find it an inspiring book about how real doctors could intervene in new ways to better the lives of real people. People like Terry McCord. People like you. Chapter 1. Group practices provide better and cheaper care. Winter in Cleveland can be beautiful when the air is crisp and the evergreens are cloaked in white. But by mid-March, with its bare trees and gray skies, a longing for something more alive fills the air. Against this backdrop, Lisa Cantwell, a woman in her 20s, saw her doctor for a prenatal ultrasound. Already the mother of 2 young children, she had been through prenatal testing before, but nothing could have prepared her for the ordeal that she and her husband, Josh, were about to face. The ultrasound, performed at 18 weeks, showed something in the baby's neck, a dark mass, 6 centimeters across. In 35 years, Lisa's prenatal specialist had never seen anything like it. Several follow-up scans that spring and summer revealed that the cyst was growing. Lisa's caregivers were concerned that the cyst would impair the baby's ability to breathe. Her case was transferred from Cleveland Clinic's community hospital to the main campus, which handles the most serious medical cases. Mother and child were admitted to the fetal care center, where a multidisciplinary team of obstetricians, neonatologists, and pediatric subspecialists would provide care. The center is not a place but a virtual team linked by purpose, protocols, and electronic medical records. When the time came for Lisa to give birth, Dr. Paul Krakowitz, a leading pediatric head and neck surgeon, discovered that the mass was just under the baby's windpipe. The baby might not be able to breathe outside the uterus. Cutting the umbilical cord could prove fatal. Dr. Krakowitz's team used a rare procedure. 2 operating rooms were prepared side by side. Surgeons waited in the second room, ready to operate on the baby if needed. In the first room, Lisa had a normal cesarean, but the baby was lifted only partially out of the uterus. Before full birth, Dr. Krakowitz performed an endoscopy to see whether the baby's windpipe was clear. It was. Baby Dominic was fully delivered and sent to the neonatal intensive care unit. To the naked eye, the baby's neck looked perfectly normal, but the cyst was under the skin and growing. It was a cystic hygroma, a large sac filled with fluid. Once they were home, Lisa carefully monitored Dominic to ensure that the cyst didn't impede his breathing. Almost every day, she checked in by phone with a nurse who ran the fetal care center. But in the second week, Lisa noticed that Dominic was turning blue. The cyst had grown so big that it was strangling her son. Lisa and Josh rushed Dominic to Cleveland Clinic's emergency department. Doctors intubated Dominic to open his airway, and Dr. Krakowitz prepared to operate. The next day, he removed a cyst running from the left lobe of the thyroid into the cervical spine, up through the thyroid cartilage, and into one of the tubes that connect the nasal cavity to the ears. These structures are tiny in a 2-week-old infant, and the cranial nerves that control hearing and speech run through them. Bleeding had to be controlled because babies don't have much blood to begin with. The operation, which took 4.5 hours, was a success. Dominic was moved to the pediatric intensive care unit, where additional medical specialists and highly trained nurses stabilized him. He was on the road to recovery and a normal life. How doctors are organized matters. No single person saved Dominic's life. His survival lay in the hands of many caregivers, highly skilled specialists who included radiologists, otolaryngologists, neonatologists, obstetricians, anesthesiologists, nurses, and technicians. The caregivers who treated Dominic were an integrated group, with each function supporting every other function. Every circuit was connected, from the top medical specialist to the nurses to the blue scrubs team that disinfected the operating rooms. Like any tightly knit team in the corporate world, Dominic's caregivers all wore the same logo, reported up the same organizational chart, and had the same signature on their paychecks. They also had the same mission: to save lives, put patients first, and advance the cause of health and medicine. And as members of a group practice, they had the protection of quality and safety protocols, cost efficiencies in purchasing, and a commitment to innovation and process improvement. For all the talk about America's healthcare system, it's not a system at all. There are about 800,000 doctors in the United States. Some of these doctors are self-employed. Some work for hospitals. Many work in practices of fewer than 20 colleagues. As of 2012, about 40% were truly independent. This small-scale cottage industry approach can deliver finely crafted services, but the quality of those services is variable, and costs are typically high. Coordination, standardization, quality improvement, and all the other factors that today make high-quality products and services available to more people more rapidly and more cheaply than at any other time in history have yet to be generally implemented in healthcare. However, the same strategies that have revolutionized every industry from textile manufacturing to farming, over the past 250 years can be applied to healthcare. The first step is to organize doctors differently, to bring them together to form much larger organizations led by doctors, not professional managers. In 2005, only 4.5% of American doctors worked in group practices of 50 or more. But this is rapidly changing. More of American healthcare undoubtedly will shift to the group practice model embraced by the Mayo Clinic, the Cleveland Clinic, Kaiser Permanente, California, and similar organizations. We will probably see more and more groupings of hundreds, even thousands of physicians. These groups invariably will and should embrace a corporate model, paying doctors a salary, tying continued employment and raises to annual performance reviews, and leveraging their size to buy high-quality equipment and supplies more cheaply. Origins of the group practice model and Cleveland Clinic. The group practice model was essentially born in the Midwestern United States. The first nonprofit group practice was established by William and Charlie Mayo in Rochester, Minnesota, more than 100 years ago. Today, Mayo Clinic is the largest nonprofit group practice in the world. The second largest is Cleveland Clinic, founded in 1921. The founders of Cleveland Clinic, George Crile Sr., Frank Bunce, William Lower, and John Phillips, were good friends with the Mayo brothers. They hunted and fished together, stayed at one another's homes, and shared ideas on the best way to organize the practice of medicine. These doctors, led by Dr. Crile, were among the first physicians to volunteer when America entered the Great War in 1917. Dr. Crile and his colleagues set up military hospitals not far from the front. They were impressed by the military approach to medicine, which was so different from the private practice model that dominated civilian medicine. Military medicine was collective. Supplies were managed efficiently. Innovations were adopted quickly. Everyone shared the same mission, and all were focused on the patient and making the patient better. When Dr. Crile and his colleagues returned to Cleveland, they saw an opportunity to create an ideal medical center. They wanted to start with a blank slate and apply the lessons of the Mayo Clinic and military medicine to create a new kind of medical enterprise. Thus was born Cleveland Clinic. Nonprofit. We are a nonprofit group practice. Nobody owns Cleveland Clinic. We are a community trust. Board of Directors. At the top of the organization is an elected board of directors. The board oversees our nonprofit mission, approves budgets, sets compensation, and manages property transfers. The board includes business leaders, philanthropic leaders, and community-minded individuals. CEO and President. Next is the CEO, who is also president of the board. The CEO sets policies in collaboration with an executive team and oversees the administration of all clinical and operational activities. The CEO communicates the organization's progress to caregivers, along with its mission, vision, and values. Chief of Staff. The Chief of Staff manages all affairs relating to the employment of Cleveland Clinic's medical staff. Staff physicians and scientists. Cleveland Clinic has 3,000 salaried physicians and scientists on staff. These professionals represent 120 medical specialties and subspecialties. All are on one-year contracts and are subject to annual performance reviews. Support and services. Cleveland Clinic's medical staff is supported by more than 40,000 caregivers, including 11,000 nurses. These caregivers include allied health professionals, administrators, clerical workers, maintenance personnel, information technology experts, financial experts, billing and appointment-making personnel, and hundreds of other job categories. All contribute to the patient care experience. Cleveland Clinic is a physician-run organization. This is a big distinction. There are good arguments for the lay administration of some types of medical centers. But more than 90 years of experience has convinced us that physician leadership is best for a nonprofit group practice. Doctors bear the ultimate responsibility for the health and well-being of their patients. So it makes sense that doctors, rather than laypersons, make the decisions about the functional activities that surround patient care. At Cleveland Clinic, a physician CEO and president, a physician board of governors, physician chairs of institutes, and other physician leaders make key decisions for the organization, albeit with the advice and consent of a lay board of directors and in collaboration with nurses, scientists, and lay administrators at every level. The authority granted to doctors may be one of the reasons that Cleveland Clinic physicians score so well on employee engagement surveys. Their collective power is commensurate with their responsibilities. The judgment of medical experts ensures that every policy and procedure implemented serves the goal of providing patients with the best care possible. Arguments for and against the group practice model. If the group practice model is so effective, why aren't there more group practices? Doctors resist the group practice model for the same reason that the Green Mountain Boys resisted the British. They like their independence. The medical profession attracts smart, capable, self-driven individuals. They can and do enjoy successful careers managing their own affairs in private practice. Traditionally, hospitals are not expected to lead healthcare. Rather, they serve as a doctor's workshop where physicians can make decisions about their patients' care without bureaucratic encumbrance. One historian noted that when recognizably modern hospitals first emerged in the late 19th and early 20th centuries, the physician hierarchy and organization was separate from the administrative hierarchy and organization. This still holds true in many hospitals today. Patient preference also plays a role. The memory of the country doctor who travels from house call to house call with a black bag is cherished, as is the Norman Rockwell image of the kindly practitioner taking a patient's pulse with a pocket watch. Given these entrenched views, the founders of early group practices were not popular with the medical establishment of their day. They were called medical Soviets, Bolsheviks, and communistic. Professional associations railed against what they termed the corporate practice of medicine. When some physicians in Palo Alto, California, attempted to start a group practice, they were barred from their local medical association. The American Medical Association countered the growing menace of the group practice by publishing a reaffirmation of what it believed were the key principles of the medical profession: solo practice, fee-based compensation, individual physician control over the services provided, and the conviction that medical institutions are but logistical extensions of physician practice. In Northeast Ohio in the 1920s, the local medical powers were so alarmed by the prospect of a group practice in their midst that they threatened the founders of Cleveland Clinic with the loss of admitting privileges at local hospitals. In response, the Cleveland Clinic Group built its own hospital, which has since grown to a 1,300-bed complex on its original site. Good arguments on both sides of the group practice controversy existed then, just as they do now. Many people believe that the group practice model sullies the doctor-patient relationship, making doctors more beholden to the organization than to the patient. Some can't shake the idea that giving doctors salaries leads to inattentive care. The laws and regulations governing medicine also tend to favor the private practice model. Some state legislatures have passed measures prohibiting the corporate practice of medicine. In its early days, Cleveland Clinic had to take complex legal roundabouts simply to collect fees and distribute salaries to doctors. But the group practice pioneers also had their champions. In 1932, a committee of enlightened medical reformers declared that many of the difficulties in present medical practice can be overcome, wholly or in part, by group organization. The recent national debate on healthcare reform, leading to the Patient Protection and Affordable Care Act being signed into law in 2010, thrust the group practice model back into the spotlight. Today, the group practice model has supporters at the highest levels of government. In 2008, for example, President Barack Obama told a national television audience that Cleveland Clinic, Mayo Clinic, and similar practices offer some of the highest quality of care in the nation at some of the lowest costs in the nation. 4 years later, both President Obama and Governor Mitt Romney mentioned Cleveland Clinic approvingly in their first presidential debate on October 3, 2012. Still, resistance among doctors dies hard. It's not easy to cast off the Lone Ranger mentality. Some doctors continue to believe that their individual brilliance will be stifled in a collaborative setting. Others maintain that getting doctors to agree and work together is a hopeless task. Dr. Harry Hartzell, a retired pediatrician from the Palo Alto Medical Foundation, once said, "3 types of people don't get along in a group. The hard-driving entrepreneur who wants to create an empire, someone who always wants to have a minority opinion, and a person who doesn't like to discuss issues, negotiate, and compromise." There are good arguments on both sides, but the success of Cleveland Clinic, Mayo Clinic, the Palo Alto Medical Foundation, and other group practices testifies to the value of this model in delivering exceptional and efficient care. Measuring exceptional care. Excellent outcomes, such as Dominic Cantwell's, are the rule, not the exception, for large medical groups, as evidenced in part by published outcomes and rankings by reputation or quality. The Centers for Medicare and Medicaid Services publishes a number of quality and safety indicators for hospitals on its website, cms.gov. Another widely acknowledged and frequently cited measure of overall hospital and specialty quality is the annual U.S. News & World Report Best Hospitals ranking. U.S. News factors in a variety of measures, from reputation to mortality rate to nurse-patient ratio, to arrive at its conclusions. The large group practices are disproportionately represented at the very top. Mayo Clinic and Cleveland Clinic are regularly ranked among the top 4 hospitals in America. Intermountain Healthcare's Intermountain Medical Center is ranked the top hospital in Utah, and its LDS hospital ranks 3rd. In 2013 through 14, Cleveland Clinic was ranked number 1 in America for cardiac care for the 19th year in a row, and number 2 in urology, nephrology, diabetes and endocrinology, digestive diseases, and rheumatology. Mayo Clinic was number 1 in 5 specialties. It seems fair to conclude from these results that large group practices must be doing something right. General rankings are one thing, but where are the more specific studies of the underlying data? In truth, accurate, direct comparisons are hard to come by. One of the drawbacks of independent practices is that they are unlikely to measure, record, or share their outcomes as diligently as the big groups do. A few studies have tackled this problem. One comparison found that patients at multi-specialty group practices received care that was 15% higher in quality than the care that patients received at non-group practices. Another study looked at care management processes, which are structured procedures for treating specific conditions or diseases. They established core treatment plans around which doctors can individualize care. Having care management processes in place makes for better outcomes. This study found that large multi-specialty group practices were more likely to have such processes in place for asthma, congestive heart failure, depression, and diabetes. If physician groups do indeed perform better, the question is, why? Much of the answer is based on how they enhance collaboration, benchmarking, innovation, the patient experience, convenience, and personalized healthcare. An even more basic common sense reason is this: group practices have an easier time measuring and improving care. Improving care. How can the performance of an entity as large and complex as a hospital be improved, given that there are so many different professionals coming together to get the job done? How can doctors, nurses, technicians, and other support staff improve, for instance, the care that lung transplant patients receive so that they can recover more quickly and stay in intensive care for fewer days? How can the many teams within a hospital uniformly sterilize surgical instruments so that patients sustain fewer serious infections? How can teams of professionals, each with different training and perspectives, improve their care of women during labor and delivery to minimize the number of risky procedures, for example, cesarean sections, that these women undergo? In business and manufacturing, quality improvement is a way of life. Leaders push managers and line employees to work together in new ways to overcome the inertia of the way we've always done it. Unfortunately, the business-as-usual model has particular staying power in health.
Sample complete. Ready to continue?